Let's start. Okay, let's start. I am Dr. Madiha Sarwat, and I have done my FCPS in pediatric medicine in 2020. I have done MRCPCH this year, and I have also done CHPE, which is a certification in health professional education 3 years ago while I was working at University of Lahore as senior registrar. So we are doing this short webinar on history taking. So as you all know, that the long case has two components. It's history and examination. Today, we'll focus mainly on the history taking. So how many of you have given FCPS attempts before? Can you drop a message in the meeting group chat? People who have already appeared. Okay, I guess everybody is giving it for the first time. So yes, in FCPS, you have one long case and 4 short cases in your clinical, and that's what we would be focusing on in our course. So today we are talking about history taking for the long case. As you all know, that history, the long case is a total of 40 minutes as per the rules. But while we are practicing, we'll always aim for a 30-minute practice so that you have at least 5 minutes to summarize your whole history and examination, and also think of the main concerns that you have. Okay, so who can tell me that what are the components of a pediatric history? We have here some names I can see. Dr. Anisa, can you tell me what are the components of pediatric history? We'll try to keep it interactive. All of us are no one is an undergrad student here. All of us have worked in the field for a while. I hope all of you are going to appear in the exam sooner or later. So we'll try to keep it as interactive as possible. So Dr. Anisa has disappeared. Dr. Hina, can you tell me what are the components of pediatric history?
So first, we need to take the biodata in which we ask the
Okay.
name of the patient,
Yes, very good.
name of patient and age, and the city from where the patient belongs, father's name, and then the mode of admission, whether it's OPD or via ER, and what are the active complaints for which the patient has brought there, and then we go for HOPC in which we elaborate the symptom, and then we think of the differentials and we rule them out, and then we ask them what labs are done so far and what treatment is given till now and what's the plan for discharge, and then we go for the like ECHAMS, history of actual diagnosis, in which we go date back, like we go back to the past, like from where the complaint started from,
Okay.
in which we think of the disease etiology, sees complication, classification of disease, whether the patient was hospitalized for how many times the patient is hospitalized for this problem, and whether the everyday life activity is affected or not, any procedure done so far for this problem, and if there's any screening is done, family screening is done for this problem. Then we go to past history. That other than this problem, if patient is admitted or had any medical or surgical issue before, for which the patient was admitted, or it has taken any kind of medication, or any past drug history, or any drug allergy history.
Okay.
Then we go for bind FSIC, in which we take birth history, immunization history, and
Yes.
a nutritional status, nutritional history actually, and what the patient has taken, how many calories are taken in last 24 hours, and
Yes.
the developmentally, whether patient was developmentally normal, whether person is studying right now, like whether in school or what's the status. So we ask the questions accordingly. And in family history, we'll ask about the siblings and the order of the what is the number of the uh, like what is the order, what is the number of the patient, like whether the
Birth
patient is
order.
second or
Yes.
third in order of the
Okay. Yes.
sibling. Yeah. And then
Hmm.
any a disease running in the family like TB or any other disease. So we'll ask
Okay.
about that, mind F sick,
Hmm.
and socioeconomically whether they are poor or good, and what's the occupation of the father, uh, how do they how they are supporting their family, and their living condition, ventilation, and and then what is the impact of the disease on the family, on the patient, and on the uh, on siblings as well. And then what are the concerns of the like parents about the disease, and what do they know, what's the knowledge about the disease they have.
Okay. Great. Dr. Hina, have you ever appeared before, or is it going to be your first attempt?
It's going to be my first time, madam.
That's very good. I am impressed that you already have a skeleton in mind. So thank you so much.
Thank you, madam.
So that's what you need actually. Now we are not at undergrad level. You are expected to take history like a consultant. So the first step in history that you need to have and that you need to be very clear about, like Dr. Hina has a clear structure in her mind how she is going to proceed with the history. Well, in FCPS, the thing is that you do not have a fixed structure. The main headings are the same, but you can always talk about um, the disease according to your problem. So, yes, as you can see, can you all see my screen? Hello. So, you can see these are the main headings. So, one trick of never missing any point is that when you are given the command to take a detailed history, you say Assalamu alaikum and you introduce yourself that I am this doctor. I have been working with children for this long. And who am I talking to? Are you his mother? And ask the name of the child, ask the name of the person who is the historian, what is the relationship. And in the meantime, you can also ask that, is it all right if I write something? Like you can ask in Urdu when your patient is an Urdu speaking person. You can say कि मैं साथ साथ लिख सकता हूँ कि मैंने कुछ इंफॉर्मेशन लेनी है आपसे इसकी बीमारी के बारे में और मैं साथ साथ लिखना चाहूँगा. FCPS में it is a huge trick to translate from the patient's language to English because we have to give the viva in English, we have to summarize in English, we have to even enumerate the main concerns in English. But you have to be very, very fluent in the patient's language. Whichever center you are appearing from, make sure you practice with those patients as well. And कोशिश करें कि उर्दू में ही practice करें ताकि आपको एक रिफ्लेक्स बना हुआ हो कि हमने उर्दू में सुना है और उसको इंग्लिश में कैसे लिखना है क्योंकि 15 मिनट एक बहुत छोटा टाइम है एक लंबी हिस्ट्री के लिए तो टिप्स एंड ट्रिक्स से ही आप सारा कुछ पूरे कर सकते हैं और ये कि आपके जहन में होना चाहिए कि ये जो बच्चा है जिसके बारे में बात की जा रही है ये अभी इस मसले के साथ आया है और मैंने किस तरह आगे लेके चलना है इसे सो वन ट्रिक इज कि आप एक पेन से अपना सबसे पहले ये पॉइंट्स लिख लें अपने पेज पे और ज्यादा लिखना भी does not leave a very good impression. You have to be very interactive, very social and also very empathetic. हम सबको पता है कि हम वार्ड्स में काम करते हैं हम बहुत तेज काम करते हैं हम जल्दी जल्दी लिख भी रहे होते हैं हम कभी आई कांटेक्ट करना भी भूल जाते हैं एग्जाम में आपने ऐसा नहीं करना एग्जाम में आपने वो करना है जो आप सोचते हैं कि 5 साल बाद अगर आप किसी अच्छे कंसल्टेंट के पास जाएंगे तो वो किस तरह से आपकी बात सुनेगा और किस तरह से जवाब देगा और किस तरह आपकी प्रॉब्लम को लेके चलेगा तो आपने उस कंसल्टेंट की नज़र से देखना है जो आप 5 साल बाद या 10 साल बाद एक अपनी प्रैक्टिस में बैठ के बनेंगे तो उस लिहाज से आपने पेशेंट से बात भी बहुत प्यार से करनी है और तरीके से करनी है। कोशिश करनी है कि जो बात पेशेंट कर रहा है उसकी फ्लो को ना तोड़ा जाए। सो इसकी एक ट्रिक तो ये है, कैन एवरीबडी अंडरस्टैंड उर्दू? बाय द वे, आई कैन सी सम डिफरेंट नेम्स हियर, सो आई वुड लाइक टू नो, डॉक्टर श्रद्धा जसवानी, कैन यू अंडरस्टैंड उर्दू? Okay, thank you so much. Dr. Ozil is saying, I don't understand Urdu. Okay, I will continue in English then, just for the sake of this discussion. But obviously, we will practice according to the center of the candidate. What I was saying is that whatever language your patient is speaking, you have to learn that language and be fluent in it. You will be appearing from your local center, most probably, and you will already know the language. Urdu is the main language that you're expected to know in exam, because even while we are selecting patients for the exam, so the thing is that CPSP does not have a patient bank like international exams. The exams, people who have already appeared, they would know that exam is conducted on the patients selected from major tertiary care hospitals in the city. So they will be appearing. Um, they will be selected a day before or a week before. And some tertiary care hospitals, they do have patient banks for short cases, but for long cases, mostly the admitted patients are sent to the CPSP center. So most of them will be speaking Urdu, because when the patient is being selected, we do make sure that the patient does not speak Pashto or is not even understanding Urdu, the parent, because that might cause a problem for the students. So, and very classical cases are sent to the exam center, and even there, the examiner has a right to choose the patient that he is going to put up for the exam. So make sure that you know that common things happen commonly and rare things happen rarely. Even if you know a patient personally, he is like your relative, and you know he has a rare diagnosis, please, please, please don't jump to the rare diagnosis. Try to take a history, a coherent history that leads to a common diagnosis, and then it and his acute concerns, and then in your list of differentials, if you do know the patient, because a lot of us will go to the hospital before the exam and see the patient, and they will know the diagnosis. Try not to jump to the diagnosis. Listen to the patient's story and try to make a diagnosis there. At consultant level, most of the time, like 70 or 80% of the time, you're not expected to defend the diagnosis. You are expected to know what are the main problems of the patient right now, and you have to examine him, and then you have to make a list of your investigations and management accordingly, which not only cater the acute problem but also talks about the standard guidelines of the management of that case, of that diagnosis, like thalassemia, nephrotic syndrome, cerebral palsy. They are all long standing diagnoses. But if the patient is admitted with a pneumonia, you have to talk about pneumonia in that admission before going on to the chronic history. Talk about the acute things first. So, the trick of taking history while you are with the patient, you have introduced yourself, and the patient is introducing themselves. Sometimes you will get very chatty patients, and they will tell you, you will say, okay, why are you here? And they will tell you, we came here a week ago, and because he had this, and this for this much, and they will tell you a lot. So, your trick is you have to see your timer for the first 3 minutes. Let the mother or the historian talk. And if the child is older than 7 years and he's developmentally normal or close to normal, then you should ask the child, would you like to add something? क्या आप कुछ बताना चाहोगे? So that way you can fill a lot of gap places in your history. Sometimes they will tell you what the chronic diagnosis is. Sometimes they will tell you the whole course of illness that Dr. Hina pointed us out to us, that they might tell you that we went to a peripheral hospital, then we came to this hospital, then we had blood tests, then we had this drips or IV fluids or medicines. So if you already have a skeleton on a paper, you can easily fill in the gaps. And then after that, you can go on to leading questions. I am saying 15 minutes for history again and again because I'm assuming that you will be doing the whole systemic examination in the next 15 minutes and summarizing in the next 5 minutes so that you have comfortable time to put your thoughts in line. Obviously, when you're going to start your practice and going to ask all the questions, you will take 40-45 minutes on your first history if you cover all bases. But if you take the fourth or fifth history of cerebral palsy in like a week, well, you're going to make it to 20 minutes. So even if you think that the time is a little short, you have to practice. This is what the exam requires. You have to be very comfortable taking history within 15 to 20 minutes. 20 minutes is the limit. Like you cannot exceed that. If you exceed that, you should be ready to let your exam go because the examiners are very mindful of the time. Although they might not be listening in very careful, they are trying to listen, but they might not be able to register some points in your history. But if you go over the time limit and you're expected to shorten the examination just because you were not able to ask all questions within those 15 to 20 minutes, that leaves a very poor impression. And in FCPS exams, the examiner's impression is very important. It's not like they're going to mark you unfairly, but you have to be mindful that everybody is human. Human bias is very real. So it's a lot about impressions, how you present, how you take history, how comfortable you are, how you're doing it like you're sitting in your clinic and it's like an everyday routine. Even if you miss some things, they are not going to notice if it's all making sense and you're close to the actual diagnosis. So, in history of present illness, well, you have to include review of the systems as well. So, that's very important. Review of the systems mean, well, if you have, um, let's say, a presenting complaint related to GIT, like the child was vomiting and then he had some loose stools, and he is also for the last 1 week, and the parent tells you that he is has some wheat allergy. Probably he's a known case of celiac disease. That's where you can ask a leading question after 3 minutes that has anyone ever told you about celiac disease? The parent might tell you, yes, we have heard of celiac. Even patients who don't know English, they know the term celiac, they know the exact terms, diabetes. So that's where you can ask a leading question. And then after GIT, it is covered in your history of present illness. You have to cover rest of the systems and you can make your own scheme. There is no fixed scheme. Just make a scheme, write it down, practice it on every history. Like when I was giving appearing for my exam and what my mentors told me, I had a head to toe systematic review. Like I would ask questions related to the CNS, then CVS and respiratory, then GIT, then urology, nephro, uro, and musculoskeletal and skin. So that would cover my whole systemic review. And in any case, you have to ask about fever, weight loss or weight gain, pattern of sleep. So if there is any systemic illness that you're missing, you might pick it up there. Past history, like Dr. Hina was here with us, and I think I am talking for a very long time. So Dr. Ubaid, can you tell me what do you ask in past history? Dr. Ubaid, are you there? Dr. Mariam Arif, can you tell me what do you ask in past history in a pediatric patient? Okay, guys, the more you interact, the more useful this session is going to be. Does anyone want to volunteer? What is past history? Yes? Yes, Dr. Mariam, I'm asking what do you ask in past history in a pediatric patient? Just short answer, like 4 or 5 words.
Any previous admission,
Okay, great.
the number of hospital admissions, and details about the admission with the maximum
Yes, good.
duration of stay, and what was treatment given at that time, and with what complaints patient was admitted, and
Yes.
what was advised
And
on the follow up.
okay, great. Thank you. So you will also add the history of travel here and history of any blood transfusion and also past medical and surgical history if the child is already taking some drugs. If you haven't asked that in HOPI, cover it up in your past history. Whatever medicine he has ever taken in his life. Like there are a lot of epileptics who have taken anti-epileptics for 2 years, some 5 years ago, and then they never had a fit and they thought, okay, we don't need this medicine, why spend on it? And they just stopped it. Now the child has presented with seizures again, and instead of looking at it as an acute problem, if they tell you that it has always been there, it is due to poor compliance, I would say, then you will obviously change your diagnosis. Okay, so our next component would be birth history. It is a short mnemonic for these 4 components. Bind, you must have heard of it. It's birth, immunization, nutrition, and development. I have written growth and development because uh, growth is basically included in nutrition when we take a CPSP history. But in standards, we include growth and development together. So, growth means has the child always been growing well according to his peers? Like you can ask, the way his siblings were growing, was he growing at the same rate? Do you think he was growing at the same rate as his age fellows or his sibling? Or was he lagging behind? That can tell you it is failure to thrive and the child has had the problem for a while, either diagnosed or undiagnosed. So, what about birth history? Dr. Nadia Kamal, can you tell me what do you ask in birth history? It's pretty much written on the screen.
Birth history, the mode of delivery, or
Yes,
were there any complications during birth, or like any instrumental delivery like vacuum extraction, or was there any history of delayed cry,
yes,
and
great. So,
and
this is like
pregnant-
antenatal. What about
yeah.
prenatal? What do you ask about a child um, who is in your clinic and you have to ask about what happened during the pregnancy? What are the main things you would like to touch?
um, Maternal, any maternal history of maternal illness,
Okay,
uh,
great.
history of maternal fever,
Okay,
or
yes, very important.
diabetes,
Yes,
or any evidence of like intrauterine growth retardation or placental insufficiency.
that's great. Dr. Mahapara has added antenatal scan. Yes, Dr. Mahapara, we will also talk about the anomaly scan or how many antenatal scans, what
Yeah.
kind of follow-up they had. And what about postnatal? What would you like to ask in postnatal?
Natal,
You already mentioned that the mode of delivery we'll ask. We'll
yeah,
also ask if the child had an immediate cry or a
yeah,
delayed
yeah,
cry.
yes, yes.
Did he have any jaundice, prolonged jaundice? Because
Founded.
in certain cases, like global developmental delays or cerebral palsy, or a child whose failure to thrive, he might have been a premature child.
Yes,
So,
gestation.
yes, Yes, it's very important to know that. Thank you so much, Dr. Nadia.
Welcome.
So, the next history is immunization. Immunization is basically touched upon only in most of the histories. You ask, has the child been immunized by EPI schedule? If you are in Pakistan, and if you are in another country, get familiar with what immunization schedules are being followed and until what age. In Pakistan, we follow EPI schedule, and up to 15 months when we get the second MMR or measles is when the dosage is complete. They are also planning to add the 18 months DTaP instead of 4 years. So, but that is not in practice yet. But get in touch with your hospitals and find out when it comes, because by your exam it might be started. So you have to ask about EPI schedule. The easiest way is card, has he been given injections according to the card, and was he given the 15 months injection? Okay, so that is how you check about immunization. But if you're taking a history of tuberculosis, let's say, and they tell you that he has had um, immunization according to card, but then you ask, when he was born, did he have a blister that had pus and then it opened, and then does he have a mark on his arm for the birth injection? Sometimes the child is not even vaccinated properly. He is unvaccinated. When you go to examination, sometimes you just skip seeing the BCG scar altogether. So asking it in history is a good idea when you're talking about infections. In nutrition, what would you like to ask in nutrition? Dr. Noor Hassan, can you tell me what would you like to ask in nutrition? Are you there, Dr. Noor Hassan? Dr. Hussain, can you tell me?
Can I tell?
Okay, thank you. Yes, Dr. Kurat, is that you?
Mariam.
Mariam. Okay, Mariam, you can go on.
How many calories child has taken in the last 24 hours? And
Okay.
in some diseases like in thalassemia, special dietary restrictions, or in
Yes.
celiac,
Or
uh,
diabetes. Yes.
diabetes, high glycemic index, avoidance of high glycemic index diet,
Yes. 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 Very good.
and in Wilson's, copper-rich diets.
Copper containing foods. That's very good. Mariam, where are you from?
I'm from Lahore, trainee of Sheikh Zayed Medical College, Lahore.
Okay, so is this your first time?
Yes,
You are going to do well, inshallah. At least you are you have used your residency well, I think.
thank you.
Thank you. So yes, as Dr. Mariam said, nutrition, that's what you need to know, all the calories that are taken. In nutrition, we will always talk about 24 hours recall, average calorie intake. We will talk about any dietary restrictions. We will also talk about breastfeeding and age of weaning, because the cases that you're going to get, half of them are going to be malnourished. So always talk about the 24 hours recall for an estimate of calories, and also about the for the variety of food. Sometimes you will find out that the child is having chai ras, and nothing else. So he might be getting enough calories, but not the right micronutrients. So yes, that's how you take nutritional history. What about growth and development? Dr. Kamila, can you tell me what would you ask in the developmental history? Okay, does anyone want to volunteer except Mariam? Guys, developmental history is pretty simple. Okay, Xiaomi, unmute your mic and tell me what would you like to ask in developmental history? It's pretty simple.
Dr. Madhya, we will ask about the motor milestones according to the age and
Okay.
along with it, speech, hearing, vision,
Yes.
all these things.
Okay. Okay, great. So yes, that's the basic idea. Thank you, Dr. Kurat. So yes, growth and development. Developmental history is to be taken in the same domains that are mainly we read in Nelson or anywhere. For a general pediatrician. We will talk about the fine motor skills, the gross motor skills, hearing and speech, and social. So you have to ask very coarse, big questions. Like sometimes you would be missing that the child hasn't achieved walking yet until the examination. When you will ask him, okay, I want to take his height, ask him to stand up. And in your entire history, you haven't asked, is he able to stand up? A lot of parents, developmental delay is quite a concern, and a lot of parents will say, my child had a heart surgery at the age of 1 year. That's why he did not start sitting up properly by 1.5 years, and he started walking at 2 years. That can be secondary to the illness. But now that you are getting more and more examiners who have done MRCPCH, developmental station has more marks and more time than a history station and all of the long stations and all the communication stations. And they know that FCPS candidates are going to struggle on this. Even when you have taken an impeccable history, they're going to ask you, okay, what is the developmental age of this child? Okay, what is this development? If you just touch upon it in your own history summary, they're going to find out that, okay, this person does have it in mind. And trust me, nobody knows development really well to actually go into the details. So it's better to just get it out of the way when you're talking, when you're giving a summary and when you're asking questions from the parent. So in social history, we combine a lot of things. So in social history, we talk about the financial history, we talk about the home structure, we talk about uh, any habits that the child has. Uh, how many of you have heard the mnemonic heads in adolescent history? A lot of thalassemia patients, diabetes patients that you're going to get are going to be adolescents. So we use the heads interview and it covers a lot of things. It's very interesting that social history, major components of social history are covered in it. It is basically a table in Nelson. I don't remember exactly which chapter is it, but it is a table in Nelson, and it has a lot of questions that cover everything related to the social history. So, can anyone tell me? Have you heard heads? At least you can Google it and tell me. No one? Dr. Namath? I think it's a new concept for a lot of people. So I will tell you. Heads is basically H stands for home environment, E for education, employment, A for activities with peers, D drugs, S suicide, sexuality, safety from injury, violence. So in this, you will get to know, is the child going to school? What kind of relationship does he have? Because examiners know that you will find out what nephrotic syndrome type it is, what complications he's going to have. They're tired of listening to the same things. And when a candidate has to stand out, they're going to ask, okay, who is bearing the expenses of the disease? Where does he live? And a lot of us, in the pressure of 15 minutes, we do forget that. So let me just write it down for you. Someone has asked me to repeat the mnemonic. So I have written it down in the messages. It's heads, like sir, हमारा sir जैसे होता है. तो okay, those are the main components of history. I will not be touching examination in this um, session. So our take home is that how will you present? That is important. When you are presenting at the level of a consultant, what do you know? What do you have to do? You have to be really fluent and comfortable and coherent. So, what I would recommend is after this session, try to write a skeleton of your own, starting with the biodata, telling the presenting complaints. Then, the history of present illness has to be told according to your command. There are two types of commands that you're going to get. One person, some examiners say, okay, tell me what did you find out? Tell me your history. You have to summarize, you have to talk about your history and examination in 7 minutes, 5 to 7 minutes. Practice giving a summary in 5 to 7 minutes. Then there would be another examiner who would say, summarize your history. And you have to give your history in 2 to 3 minutes. And that's where the trick comes in. You have to write a skeleton for both. That how do you cater to both? Like, for instance, if you have an acute history, you tell my patient Ali, son of this. You don't have to tell that in summary. You can say Ali, 9 years old boy, presented to our emergency 5 days ago with the complaints of headache, fever, and abdominal pain for 5 days. On detailed history, he is a known case of celiac disease for the last 5 years, first diagnosed at the age of 1 year, with poor or good compliance, with multiple hospital admissions, and now has presented with throbbing headache radiating to this site and associated with these features. On systemic review, his systemic review is unremarkable. He was born full term to consanguineous or non consanguineous parents and fully immunized for his age. Like, you have to say one word for each domain after you have given the pertinent positive points. And then, the same way you would talk about your examination, you would say his growth centiles. You will talk about his growth centiles, then you will talk about the major system that you examined and rest of the systems if you find anything positive. Otherwise, you can say rest of the systemic examination is unremarkable. This takes barely 2 to 3 minutes. The way you present, Dr. Sid is asking me what is the heads the abbreviation for. You can look it up in Nelson, and wherever you see, you can see it on Google. I'll share the link later in the group for this. So now you will be given two kinds of history. Most of the time, it will be a chronic case with an acute problem. But sometimes, very rarely, if there are no chronic cases available, well, you can get an acute history. My long case was acute rheumatic fever. The child did not have any deformity. It was her first hospital admission. She had a heart problem, according to her mother. She was 12 years old, and It was a very complicated history until I examined her and I found out that she has a grade 3 murmur in the mitral area, radiating to the axilla, with no thrill, no chest deformity, no failure to thrive. She was perfectly well for her age, but she was complaining of arthralgias. But on examination, she did have arthritis. So I had to defend that, and Alhamdulillah, it went well. But it happened because I had it in my mind that the child may look very normal. In the same way, people have had inoxaparin purpura as their long case. The child looks well. He has a rash on his buttock. Otherwise, he is well thriving. He has never had an admission before. And there he comes with inoxaparin purpura. It might be the first admission for a nephrotic syndrome, and it might be the first admission for diabetes. Like the child had DKA, and then he got better. Then he came to your exam center. So always keep in mind that it might be the first admission, in which case the child might be well thriving and the parent may have a very small problem list. So what you can add to your problem list, the main concerns of the family is they have inadequate knowledge about the disease. If it's the first admission, we have all worked in government setups, in private setups, wherever we don't get enough education, disease education on our first contact. It takes years to actually educate a family about the pertinent screening, trans- transmission, the why did it happen, what can they do to make it better, what nutrition they need. So yes, it's you can always add that to your list of problems, that the family is unaware of the disease problems or how the child's life is going to be. So, but, and the Viva will also be very complicated for an acute history because you have to defend the diagnosis and you also have to give a problem list that the child might face. Okay, we'll take questions at the end. So this is how you present. And how do you manage time? Like I said, history 15 minutes, examination 15 minutes, summary 5 minutes. And then 5 minutes, just calm yourself down, work on your nerves. This is like you have to aim that you will only meet the examiner for a long case once in your life. And this is it. And you have to make the best of this chance. And you have to talk to the examiner by with the best of your efforts, but also make it look effortless. So it is a paradox that you have to practice. It has to look like that you do it every day, and that's how you spend your residency, and you are fit for becoming a consultant. So my take home message to all of you would be practice, practice, practice. And I would say that never believe anyone who tells you that FCPS is a very luck-based exam. It's not going to work out if you work hard enough. In your heart, a lot of people who are appearing for the second time, when they pass the second or the third or the fourth or the fifth time, they do find out, they do believe, know that they have prepared a little better this time. They have done something that they didn't do previously. Maybe they didn't do enough past papers, maybe they didn't do enough practicing sessions, maybe they just listened into histories or they read from the books. They didn't actually speak. It's a speaking game. You have to talk to the patient, speaking game. You have to tell a summary, speaking game. You have to defend against your examiner, speaking game again. So the more you practice narrating a history, the more you practice taking a history, the better you're going to get. If you think you have read everything, you know Nelson by heart, you know all the examination books by heart, and you haven't practiced it with a real person who is taking your viva, a person who has preferably past the exam, um, you are not well prepared. You are not prepared enough. I would say try to practice with people who have cleared the exam, cleared it early, and who know what they are trying to, because it is you are way more knowledgeable than the person sitting at the other end. That's what my mentor, my supervisor told me when I was practicing with him in a short cases class and I was getting confused, and he told me, right now, you know a lot more than I do. And trust me, he is someone who knows everything. I don't know. And he told me this. And he told me that you have to believe this. But the way I am sitting across the table, it is your exam and not mine. So you have to fight for it. And always believe that if you're well prepared, and you have practiced enough and you're fluent and you're sensible, nobody is going to fail you. But if you're jittery, you're asking all the wrong questions, you're not telling them, you're not showing any empathy to the patient, you are acting like this is the first time you have ever faced a patient, or you're not an adult and you haven't talked to another adult taking an exam. It's like an interview. So you have to be very comfortable and confident, yet very professional, because that's what you're supposed to do in an exam, and that's how good consultants behave. So practice what you need to portray on the day of examination. Never practice without a timer. Always practice with a timer. Don't think that I have memorized all the questions. I will ask the patient all the questions and then I will make a summary. Then I will know you're that's the wrong approach. Read the questions as many times as you want to, and then practice them in front of the mirror. Record yourself, listen to yourself. How do you sound when you're giving a summary? You are your own best judge. So that's what I would want to say. And any questions? I'm ready to take questions. You can open your mic turn wise and then you can ask questions. We'll take questions for another 10 minutes and then we'll wind up. Okay, I think Dr. Mariam Arif, do you have any question? You were the most active participant, so I would like to know if you have any questions or any feedback. Not there. Anyone else? Do you have any questions? Yeah, you have understood everything or you have understood nothing. Which one is it? Dr. Hussain has asked me a very specific question of high-grade fever with shortness of breath. Well, Dr. Hussain, when we'll be talking about respiratory system or CVS, then we will talk about it. All these things are given in books. We are not going to discuss any specific topic right now. Is there anything you would like to ask about taking a history or time management or anything you would like to add that I skipped? Nobody has a question? So I would be asking, when are you guys appearing for the exam? Dr. Kamila, when are you appearing? Dr. Kurat is saying she is appearing in the coming year. She hasn't booked an exam yet, probably. What about everyone else? Dr. Nemat, Dr. Hussain, Dr. Mapara. People are leaving at the speed of light so that I don't ask them questions. Guys, if you are going to appear in an interactive exam and you are going to run your own clinics, talking is the primary skill that you need to learn, yeah. Don't be scared. Okay, Dr. Hussain is also appearing in the coming year. And someone said that we should conduct a session on short cases. Yes, we'd be planning classes like that. We'd be doing short cases once a week and long case once a week, topic wise. My friend and my the other mentor, Dr. Shafaq Tabassum, she is going to host a webinar soon enough. Stay tuned. And it might can be on short cases. Yes, we are yet not decided on a topic, but it can be on the short cases. Okay, guys, any feedback you would like to give before we wrap up the session? You can write it down in the messages box in case you're very shy to talk and you don't want anyone to listen to your voice. Yes, Dr. Shraddha, we will conduct a short cases session. We will be starting at the end of November, and it will be a paid course for FCPS preparation, clinical preparation, and we will be doing a weekly short case session. About the free webinar, I cannot promise you anything because we haven't decided the topic for the next one yet, but we'll definitely consider talking about short cases. So, any feedback, guys, or should we wrap up? Okay, guys, since nobody has any questions and I see some thank yous, and it was a nice session. Thank you so much all for your time and looking forward to be interacting with you. At this level, I don't think I will be teaching you anything you already know. And if we go chapter wise, you would come well prepared. All of you would be joining the course sooner or later. I think it will be very fruitful for you. And thank you for joining in and sparing time from your busy routines. Allah Hafiz, take care. Well, to answer Dr. Shraddha has a question now when the session is ending a little. Well, the short cases and long case have to be passed separately because if you fail any of those, you don't get enough marks to pass. So you have to pass them separately.